It's a pleasure to be here. What I'm going to talk to you about is our experience of using the endpoint management as well as the multi-spot Pascal laser with the long-term experience that we've had with the multi-spot earlier, and then of course going on to the EPM for various treatments that we do. So going on to the Pascal, of course we all know the advantages of a multi-spot laser. It changed the way that we were lasering from a single spot to going on to a multi-spot as far as the surgeons go and also as far as the patients go. The whole comfort levels of treating patients changed a lot. And you can see here how fast one can do PRP sittings on a patient who's diabetic or vein occlusions, and it saves us a lot of time, and so it does for the patients. And the burns are very uniform. We don't have to manually do separate burns which are non-uniform to a large extent. And then of course the role of macular laser is where the whole problem is. We are still trying to figure out where the anti-VEGFs fit in and where the lasers fit in. Is there a combination required? What exactly is the best way to treat these patients? And why has that changed? It's because of the advent of steroids, which are intravitreally given, anti-VEGFs, which are intravitreally given, and also the OCT findings, which tell us a lot more about what type of edema is there. In the past, without the OCT, we used to keep treating with laser and used to call a lot of edemas as non-responders, and at some point used to do surgeries for them. But once the OCT came and it started showing us that, oh, there's a cystoid edema, there's a spongy edema, there's a traction, and we could differentiate which patient would respond to what kind of treatment. So you have these various patterns which are seen, the spongy, cystoid, subfoveal serous, or the taut posterior hyaloid with a traction. So if you have a edema like this, which is a generalized edema, it responds very well to a laser-based treatment. You go and you would treat these areas which are showing up with cercinates, and they should respond very well. While if you have a cystoid, no matter how much laser you keep doing, you're not going to get a great response. You might add up to the inflammation, and it may worsen it for a while, and we call it a non-responder. So here the injections are what is required. Also for cystoid edema with these subfoveal sensory fluid, these are also the similar types where you need injections to decrease the volume of the fluid and reduce the edema before you could start treating these patients. And then of course you might see a frank traction which is holding on. Now here neither the laser nor the injection is going to work, and you need a surgery, and then as an adjunct you might need to do either a laser along with it or injections to reduce the edema. So a patient like this, which has well-defined cercinates, will respond quite well to just a laser-based grid treatment. As you can see, the cercinates have disappeared to a large extent. And then you can assess on the OCT based on how you want to continue the treatment. Is there still recurrent edema? Injections are required or not? So when you do grid laser, with the Pascal, it's very easy to customize the grid based on the area of thickness. So you could have these semicircular grid patterns which you could do. This is of course the non-EPM. We'll go on to the EPM version, which is what we do now as a mainstay treatment to these patients. But this is the non-EPM variety, which is still very effective because you get these very fine uniform burns and you can customize the patterns to treat these areas. These are examples of patients who've had combinations with anti-VEGF and laser. You see a thickening on the macula which is there. A patient with almost a 6 parts vision because it's got a mild, but there is a distinct edema, and then there is a separate area which has got a macroaneurysm like formation which requires a laser to that area, and it responds very well. And then you have this patient again with a containing cystoid spaces, also spongy thickness. So you reduce the edema with Lucentis, and then you treat them with laser. Or a patient like this who comes to you with significant cystoid edema, your first aim would be to reduce the edema because laser may not work right away. You first reduce it and then do the laser at a secondary stage. So coming back to multi-spot advantages before we go on to the EPM is the uniformity of the spots, which is a big advantage that we can gain. So there's less collateral damage, there's less fluence used, as we all know, because of the short pulse duration. Average fluence with the normal lasers is about 127 joules per centimeter square, while a Pascal would do equivalent burns would do only about 30 joules. So you can imagine the collateral damage is very less. And then if you look at these red-free images, look at the way this is laser burns which you see, which have been done on a manual one, which is GLX-based burns, where you see overriding of the burns, non-uniform burns, as compared to a Pascal-based PRP where you see these extremely uniform, and which is also good for the fields of these patients to a large extent because peripheral fields are compromised. We had published this data on the fields and the quality of vision improvement for the patients in 2009, and then also presented it at the academy at that time. Eventually, we did some rabbit eye and human eye comparisons of the two types of laser. You see on the top has been done with a single spot, and the bottom is done on the rabbit with the Pascal, and then we did histopathology on these eyes, and then you can see the difference here. Now, at the top is the control, the central one is the Pascal-based small burns which you see in these areas which you see here, and then of course the lower one are the GLX, which are much wider collateral damaging burn, and we presented it at the Asia RO. And then we had a patient who was undergoing enucleation for a melanoma, and in an area of the retina which was well attached and did not have fluid. After taking a consent, we did comparative burns on the same eye, and we could do it on the human eye at that point to show the difference of, on the right is the Pascal, on the left is the GLX, and you can see how the layers are affected differently if you use the short pulse duration Pascal-based treatment. Now this brings us to the next level, which is the endpoint. Endpoint is something, in the micropulse was what started the subthreshold the concept, but the problem with micropulse was that we cannot see the burns very well. We presume that this is what we are treating, and many times we overlap those burns, and even when we treat these patients used to go out and somebody would say, oh, you've not been lasered at all, there's nothing done on the eye. And slowly a lot of people started giving it up. But the endpoint actually does subthreshold and allows you to know and see what area is treated, and allows you a much better control over the treatment. So what it essentially does is, if you look at any kind of a square grid, you can have the 4 red dots at the ends. They are the ones which you would titrate to a mild gray-white burn, and all the rest of the spots in between could be a 30% or a 40% duty cycle. So they are barely manifesting, but you know that you have titrated those red spots, and these burns are that much percent less as compared to this burn. So they are manifesting, and plus the peripheral red burns act as markers. So you know that this is an area you have already treated, and there's no need to overlap that treatment, which is more difficult to do with micropulse treatments. So just to show you an example, this is with the endpoint. It's difficult to make out the endpoints, but basically what's happening is that you have the aiming beam of the grid, and then you see the ends of these, the 4 ends would be marked. As in a little while you'll start seeing those ends which are marked, and the ones in the center are manifesting much less. Now this is with the PRP just to demonstrate what is happening, but the actual purpose is used for the macular lasers where you need a much more finer treatment. But this is the concept what the endpoint is based on to explain. And this is how it is seen on the animal eyes. Levinsky and all published this data, and this is what started the whole interest, that you can have different levels of burns, and some of them are barely visible as you go on to the lesser duty cycles of these burns. And again, if you look at these diagrams, you can see the marking points are seen in the grid which is treated on the macular lasers, but the rest of the spots are so fine that you can barely make them out, and that is what we want. This makes sure that we have treated that area, but it also tells you that there's no need to overlap that area in the true term. So these are pictures of the endpoints which are seen without all the other laser marks seen very well. These are some of the examples from cases that we have used the endpoint. You see previously treated laser marks on the left which are seen, and then we top it up with the endpoint laser which is seen, and you can see the OCT regression taking place after the treatment for these patients as far as the cercinates go. This is again another patient. You see on the left the cercinates which are aggregated, and then you do the endpoint of this treatment. I was doing it earlier at about 40%. Slowly, after seeing Levinsky's results, I've started doing much lesser treatments, but I'm showing you some of the treatments that we started using, and I was still trying to use more visible burns because you want to see some treatment, but slowly we have to get used to the idea that maybe we don't need to see every burn which is coming, as long as you know that you've titrated it well, and you're probably not even going to see the rest of the burns. So this is how the regression takes place. Or if you have a thick cystoid edema, you also need anti-VEGFs along. So this is not going to work only with a laser alone. So you give a combination treatment, and you see these endpoints which are there. I don't know if you can see them, but these are some of them are these endpoints which you see. All the rest of the laser burns are not seen very well, and even clinically you barely see these burns to a large extent. But in the end, the regression is fantastic, and it prevents recurrences to some extent. So this is just to show you the pre and the post of the same patient treated with a combination of anti-VEGF as well as the EPM-based treatment. This is again the other eye of the same patient, the pre and the post treatment laser that you see. This is another patient, again showing you mild cystoid edema, which is there in these cases, and then you see the laser burns which are seen on the red free but hardly seen on the color picture that is there. These are marks which are seen immediately post laser, within a few minutes of the laser, where you see them more prominently. As I said, this is when I was using about 40 to 50% of the burns, but now I do it even lesser than this, and you barely see this. And this is how you would see it. This is after a month, you barely see the marks which have been used for the treatments, and the regression takes place. So these are more examples of the similar cases that you are seeing of regression taking place. And typically what you would see is these marking burns on the cercinet. And of course on the periphery, if there is edema, you can do square grids along which you see some of the marks in the periphery. But the central macular area only shows you the marking burns, and the edema on the OCT goes down quite dramatically. This year, early April, this couple of these presentations we did published in Retina Today as well as Ophthalmology Times. Going on to the branch vein occlusions, we all know that the natural course of branch vein occlusion, although good, is not something which goes on to give you a 20/20 vision if the patient is untreated. So we have understood now that we do need to treat these patients with some sort of treatment, most likely anti-VEGFs to a large extent, or with or without grid laser in them. So these are typical cases of vein occlusions which respond very well to anti-VEGF, but we all know that there is a recurrence. It's not a finite treatment that we do in these cases. You'll get great result in a month with anti-VEGF. The second month the patient comes back. So for these also, what we do is we give a loading dose of 3 injections, but when the patient comes back for the second injection, we like to go and do some grid laser to these patients. So we give an anti-VEGF followed by a grid laser to these patients. The patient comes back in a month's time, and this is how we would do it. And if you look at the OCTs we titrate, you can barely see the very fine burns which are made. They are not seen clinically as much, but you'll see them on the red-free images and on the OCTs, a mild grid, which actually helps prevent the recurrences to a large extent in these cases. Then, of course, if you have a frank ischemia, you need to do a full-fledged sectoral laser to these kind of eyes which are there. So there, of course, you require a full laser. Now, this is a single spot laser. You can see how overlapping these burns are as compared to something like this, which we now routinely use the Pascal for getting these uniform burns which are there, so that you do it in a much more fluent way, less fluence is used, and of course the field of vision for the patient in some ways is better preserved for these eyes. And then going on to the central vein occlusions, again the same thing. If you have ischemic vein occlusions, we like to do PRPs to these patients, and you can see the uniform PRPs that come along for these patients. But then if you have a non-ischemic one, we most of the times use either anti-VEGF or an Ozurdex molecule. A patient like this, we had used Ozurdex, and you can see the regression taking place after a month of the edema and the hemorrhages. But then they also have the same problem. They get better the first month, second month. By second, third month, the edema starts coming back. And here again, we like to do light PRPs in these patients in the periphery, because there is distinct belief that if the peripheral non-perfusion is there, which is now more often found by these optos-based wide field imaging, it might be constantly letting the edema come back, and so you're probably better off burning some of these peripheral areas with laser. So what we do is that if we have a recurrence, we inject the Ozurdex again at third month, and at that time we do PRP as well. So here you can see actually the Ozurdex implant is still there inside, and then we do PRP to supplement it in these cases to a large extent. So vein occlusions are the other area apart from diabetic edemas where you could combine the role of lasers along with that. Of course, for CRVO there is no role of macular laser. BRVO, of course, there is a role for grid laser in these cases in a combined way. And then if you want to laser them in a more fun way, you could have different patterns instead of the standard ones that you have. So sometimes when you're in a lighter mode, you could try out different patterns. You'll achieve the same purpose at the end of the day. You could have these semicircular burns that are there. These are just examples of that. Now the grid laser part of the BRVOs, we also do the EPM based treatment. So you do these, you can see the endpoints which are seen as a part of the square grids, and the central marks are barely visible. And so your aim is to do the least possible damage to the macular area, and you can probably achieve it best with EPM because you also know what part you've treated. Unlike micropulse where you just don't know what you've treated, you just keep overlapping the same area again and again in those cases. We recently published data related to these BRVO treatments as well, and this is just a picture showing you the overall pattern of a CRVO with a well-treated Pascal in the periphery. Thank you very much.